Crystal-induced arthritis is a type of arthritis caused by the deposition of crystals in the joints, leading to inflammation. The two most common forms of this condition are gout and pseudogout. 1. Gout. This occurs due to the accumulation of uric acid crystals, monosodium urate, in the joints, particularly in the big toe, but it can affect other joints as well. Gout attacks are often sudden, severe, and characterized by intense pain, redness, and swelling. High levels of uric acid in the blood, known as hyperuricemia, can lead to crystal formation. Pseudogout, also known as calcium pyrophosphate deposition disease, CPPD. Pseudogout occurs when calcium pyrophosphate crystals deposit in the joints. This form of arthritis commonly affects larger joints like the knee, wrist, and hip. Pseudogout symptoms can resemble those of gout, but are caused by a different type of crystal. Management of crystal-induced arthritis typically involves acute attack treatment, nonsteroidal anti-inflammatory drugs, NSAIDs, colchicine, or corticosteroids to reduce inflammation and pain. Long-term management. For gout, medications to lower uric acid levels, e.g. allopurinol, febuxostat, and lifestyle modifications to prevent future attacks. Uh, Regular follow-ups with a rheumatologist like Dr. Ahmed Rashdi Alagami are important for managing these conditions and preventing complications. Crystal-induced arthritis encompasses various types of arthritis caused by the deposition of different crystals in the joints. Below is a list of the known crystal-induced arthritis conditions. 1. Gout, monosodium urate crystals, caused by the accumulation of uric acid crystals. 2. Pseudogout, calcium pyrophosphate dihydrate, CPPD crystals, also known as calcium pyrophosphate deposition disease, CPPD. 3. Calcium hydroxyapatite crystal deposition disease involves the deposition of hydroxyapatite crystals commonly associated with calcific tendinitis or periarthritis. 4. Calcium oxalate crystal deposition, often associated with chronic kidney disease or dialysis, leading to arthritis. 5. Basic calcium phosphate (BCP) crystal deposition disease includes a group of conditions where basic calcium phosphate crystals deposit in tissues, leading to inflammatory conditions such as Milwaukee shoulder syndrome. Each type of crystal-induced arthritis has its own characteristics, treatment approaches, and potential complications. Diagnosis typically involves imaging and synovial fluid analysis to identify the specific crystal type. Calcium pyrophosphate dihydrate crystal deposition disease, CPPD, commonly referred to as pseudogout, is a type of crystal-induced arthritis caused by the deposition of calcium pyrophosphate dihydrate, CPPD, crystals in the joints and soft tissues. CPPD can mimic other forms of arthritis, most notably gout and osteoarthritis, which can make diagnosis challenging. Below are more details about CPPD. 1. Pathophysiology, crystal formation. CPPD crystals form due to the breakdown of adenosine triphosphate, ATP, in cartilage, leading to an excess of inorganic pyrophosphate, which combines with calcium to form CPPD crystals. Position. The crystals are deposited in the cartilage, chondrocalcinosis, synovial fluid, tendons, and ligaments. This deposition leads to inflammation, joint damage, and clinical symptoms. 2. Risk factors. Age. CPPD is more common in the elderly, particularly those over 60 years old. Genetics. Familial cases of CPPD have been reported, especially in younger patients, suggesting a genetic predisposition. Joint trauma. Previous joint injuries can increase the risk of developing CPPD in the affected joint. Other conditions. Certain metabolic disorders such as hyperparathyroidism, hemochromatosis, hypomagnesemia, and hypophosphatasia are associated with an increased risk of CPPD. Factor 3. Clinical manifestations. Acute CPPD arthritis, pseudogout, characterized by sudden onset of pain, redness, and swelling in one or more joints, often involving larger joints like the knee, wrist, or ankle. The symptoms can last from days to weeks. Chronic CPPD arthritis, similar to osteoarthritis, with progressive joint pain and stiffness over time. It may involve multiple joints. Chondrocalcinosis, the presence of calcified cartilage seen on X-rays, which may or may not be associated with clinical symptoms. Milwaukee shoulder syndrome, a rare presentation associated with large destructive shoulder joint effusions, typically in elderly women. For diagnosis, imaging, X-rays can reveal chondrocalcinosis, which appears as linear calcifications within the cartilage. Ultrasound and CT scans may also assist in detecting crystal deposition. Synovial fluid analysis. Microscopic examination of synovial fluid is key to diagnosis. CPPD crystals are rhomboid shaped and positively birefringent under polarized light, differentiating them from the needle shaped negatively birefringent urate crystals seen in gout. Blood tests. While there are no specific blood tests for CPPD, tests may be performed to rule out other conditions, e.g., gout, rheumatoid arthritis, or to identify associated metabolic disorders. Number 5, treatment, acute attacks. Management of acute CPPD arthritis is similar to gout. Non-steroidal anti-inflammatory drugs, NSAID, colchicine, and corticosteroids, oral or intra-articular injections, are commonly used to reduce inflammation and pain. Chronic management. In chronic cases, joint protection strategies, physical therapy, and medications like colchicine may help prevent flares. Long-term use of low-dose corticosteroids or NSAIDs may be considered in recurrent cases. Treatment of underlying conditions. If CPPD is associated with a metabolic disorder, e.g., hyperparathyroidism, treating the underlying condition can help manage CPPD. 6. Prognosis. CPPD is generally a chronic condition that can lead to joint damage and disability over time, especially if left untreated. However, with proper management, many patients can control symptoms and maintain a good quality of life. 7. Prevention. Since CPPD is often associated with aging and other metabolic conditions, there is no definitive way to prevent it. However, managing underlying conditions, staying active, and maintaining joint health can reduce the risk of severe joint damage. CPPD is a complex and sometimes underdiagnosed condition, making it important for individuals with joint pain and swelling to seek proper medical evaluation and treatment.